sometimes makes me cry is when you know that they haven't walked for a long time. You know, they come in wheelchair bound. And the first day, like if surgery is today and if pain is manageable, the next day I get them to stand. And when they go like, this is how it feels like. It feels like coming home because it's something that they've been wanting to do for a long time.
Specialist Centre isn't your typical hospital. It's Malaysia's premier quaternary hospital where rare, complex and next-level care comes to life. This is Quaternary Care, where our team of trusted super consultants are here to take on your toughest health battles using advanced technology and research-backed treatments all under one roof. Now, back to Nadia Azmi for UMSC's QRATED podcast.
Hello everyone, welcome back to part 2 of QRATED. We were talking about the unseen preparation that goes on before a patient needs to go into surgery, and we have zoomed into elderly patients who need to go through major procedures like joint replacement procedures. Now, for this part 2, we're going to focus more on the recovery process and also the joint decisions on replacements that need to be made. So, I'm Nadia Azmi, your host. We're still with our amazing, very terrific, superb doctors. Professor Dr. Azlina Amir Abbas, a consultant orthopedic surgeon, and Associate Professor Dr. Mohd Nahar Azmi Mohamed, a consultant sports physician. Both are from Specialist Center or UMSC. So now we've already talked about the preparation that goes on before a surgery takes place, whether and also the measures or the things that need to be taken, the steps that need to be taken in order to ascertain whether a patient is ready for surgery and fit for the table in the OT. Now let's zoom in or narrow in into the recovery process that happens after that. Prof. Azlina, a patient will probably often ask you, do I really need a joint replacement? Do I really need to go into a surgery, right?
Okay.
So how do you guide patients through this decision, especially those who are still unsure? How do you manage their expectations? And also around implant lifespan, what do you tell them about all this?
Okay, that's a very loaded question. I do get that question a lot actually. Do I really need this surgery? And because a lot of patients feel that I have pain equals I need surgery. When they do present to me in the clinic, among the key things that I really have to try to ascertain right from the beginning is how bad their quality of life is affected. Because that really does dictate whether you really need the surgery or you don't at all, or you may need it, but maybe a little bit later. In a lot of instances, when patients say the pain is so severe, I can barely get up and walk, a key question that I normally ask, look, how are you walking around the house? If even that is so difficult for you, you might need surgery.
Okay.
A lot of patients also think that it's based on what they see on x-rays, right? The x-ray looks bad means it must be bad. I need to have it done. But we've also seen patients where the x-ray is the worst looking thing you've seen, but they feel fine.
Yeah.
And if you feel fine, maybe it's not that bad and you can afford to wait.
Yep.
So the key thing about that determines whether you really need surgery is the degree of pain you have.
Okay.
And how badly affected is your quality of life,
Okay.
right? Those to me are the key factors. The other things like, your kaki bengkok ke, or that's not the most important, because it's not cosmetic surgery. It's meant to improve your quality of life. And what I always tell patients is, if you don't really have that much pain, surgery is pretty painful, you think you can cope with it. And we have seen patients where not much pain, insist on surgery, then they realize, oh my God, it is painful. And that delays their rehabilitation, that delays their functional recovery. Because, when it's painful, nobody wants to move. It's fair. If I were in that boat, I wouldn't want it to.
Become immobile. So, that affects your daily routine.
Exactly. So everything is just delayed from that. But we have seen patients where pain is so severe that when they have surgery, they go, oh, it wasn't that bad.
It's heaven sent, compared to what they were experiencing before.
Because the pain before was so painful that they just can't bear that. Surgery pain relatively is not that bad.
Yes.
So I think whether or not you really need surgery really depends on you, your quality of life. I've advised patients even where, they have family members that telling them,
Yeah.
you better do it. You better do it.
Yeah.
But I've had this with one patient before, and she looked very stressed because all the family was like, go do it, go do it.
True.
And I just told her, look, auntie, it's your knee.
Mm.
You're the one who's going to feel pain. So you better decide whether you want it or not. And giving her some time to think about it,
Yeah.
actually, they came back and go, she decided. Yeah, I think this is what I need.
I think mentally as well, the patient has to be in the right frame of mind or
Yeah.
state of mind that they are ready
Yeah.
to go into the OT.
For anything that you want to do, if I wanted to start going to the gym, it can't be
Yeah.
Prof Nahar telling me go
Go
gym. Like what I told you, go hiking.
Hiking.
You know,
No.
mentally, are you prepared to go hiking?
yes.
Right. So, the acceptance from ourself is actually the most important thing.
Interesting. So
Yeah.
that's the decision-making process. Like,
Yeah.
let's go now to post-surgery,
Okay.
where the patient has already gone through that major hurdle of the surgery process or procedure itself. Now, can patients truly go back to a normal routine? I know that it can be even more painful in the long run post-surgery, but can they go back into their daily habits like before after joint replacements? What are some of the realistic expectations that you can let the audience know that are watching us that they can expect post-surgery, especially regarding physical activity or mobility? Prof. Nahar?
Yep. Okay. Thank you for that question. So, yeah, it sounds like very formal. Yeah. Okay. I have a number of patients done by Prof. Azlina came to me, and after a period of time, they can still return back to their activity level, go out for walking, for example. Of course, when they first come, start gradually. Okay. Immediately after operation, you have to remember we have another team where a special physiotherapy session by post-operative of arthroplasty team, meaning that a physiotherapy meant for those gone for hip replacement and knee replacement. There's a special team. So it's under
Different, yeah.
they will work together closely with Prof. Azlina.
Okay.
So they will close. So during that period of time, maybe about 2 months, I may not involve directly.
Okay.
I will look immediately after that. First and foremost, after operation, like Prof. Azlina said, pain. So there will be pain management. The physio team will do the pain management kind of modalities.
Okay.
And then they need to improve their range. The range, the knee,
How much
whether
they bend.
can bend, how much they can bend. So they will do that. And it's very painful first 2 months.
Sure. Yes.
A very painful first 2 months. That the how painful it is, that what I've heard from patients when they come to see me after the 2 months thing. And then some of them still continue doing the physio after 2 months, but some of them have out of that and then will come back to me to recondition them before they go back and return to their activity level. But for the first 2 and 3 months, they were closely looked after by the team of physiotherapy, specialized physiotherapy, work closely with Prof. Azlina.
Okay.
So yes, to answer your question, they can go back. I have a number of patients and Prof. Azlina patient, even other patients outside. They come and then we start condition them back and go back to their physical activity level. Simple as brisk walking and even do other activity that they loved before.
Yeah. But to instill that discipline into your patients,
Yes.
as doctors, you not only look at the medical aspect, but I think it requires a lot of patience from you on your end
Yes.
as well.
Yeah.
Yes, definitely. Encouragement and motivation, because some of them may feel a bit, how come I only able to walk 1 km? I walk very slow. I told them, any improvement is an improvement.
Mm.
So we need to keep them, motivate them. I need to motivate them and keep them moving on.
Yeah.
Otherwise, they will stop. That's where for this patient, usually I will see them very
frequently.
frequent.
I see.
I think it's not just motivation, it's education.
Education.
A lot of patients think, okay, if I have a joint replacement, I cannot do this, I cannot do that.
True.
So we try to educate patients in terms of the do's and don'ts. That is one. Adalah pantang larang dia kan. But if you're in a good physical condition, a lot of things you can do. So one of the few things that I do before surgery even that influences their post-op recovery is I really do educate them. Look, after surgery, when you come out from theatre, this is what you can expect. You will have a drip. You may have blood being transfused. You'll have, this machine on you or that machine on you. I'll give you many different types of painkillers. Please don't be macho. Just eat it all. Because a lot of patients are worried about medications.
Right.
But, you are in pain. Even though you may not feel it at the moment, the medication is meant to prevent the pain from even coming to haunt you.
Yeah.
Prevention is always better than cure.
Definitely.
So I said, just take it. And with all the patients that we've been through, everyone says the first 2 days after surgery is the worst. And by the third day, generally should be better. And so I prime and I educate patients about this even before surgery so that they are aware that this is coming. So it's not a shock to them like, oh, I didn't realize it was that painful or what have you. And usually when you educate patients and they're aware, you get more cooperation, I think, for patients. And then they realize, well, she wasn't lying when it was painful the first 2 days. So they are mentally prepared.
Okay.
And it's true, by the third day, they feel better, fourth day, etc. And I tell them the days after that, it does improve. Now, going back to your original question, can they go back to normal activities? Actually, if that's their intention, niat dia is to go back to what they wanted to do before, and they're willing to put in the effort to it, the exercises, from physio to, sports mats program. God willing, yes, you can. So I've had patients go back to golf because they said, I want to do it because I want to play golf. I said, okay, I cannot walk my 9 holes or 18 holes. Okay, let's have it done. And this patient, like within 4 to 6 weeks, I think, because he was motivated to do it. I've had patient who was a marathon runner before and had, joint problems and had it done and pretty soon went back. She recently sent me updates. She's the fastest in her company in a 5 kilometer run. She does hikes. She does things that I told her don't do, but she still does.
Okay. Again,
splits.
doctor's advice. Is that
Splits.
Oh,
She's doing
dear.
splits. I'm
Are we
like,
talking about the elderly still or no?
she's a little bit younger, but so I mean, if and the literature supports it, like if that's your high functioning condition pre-operatively, that means you are already physically fit. There's a good chance you can go back to it. Go back to tennis, badminton.
I think this
maybe
is
not rugby lah, but
I think it's very important for the patient to know whether they can go back to their normal daily routines. It means a lot that if they can, because that's who or how they define themselves. It's how they live their life, through passion, what drives them, what interests them. So it's really important that they have some form of security. That they are able to go back to some form of normalcy after surgery.
Actually, you see, different generations have different expectations.
Okay.
The very older group, so you're talking about the 70s and the 80s, their requirements are, I just want to be able to get out of bed and, maybe do short travels with my family. That's their aim. I find those in their 60s, because again, the generations, the way they move, they are very much more active. They are the ones who still want to do all of these things that you go like,
Hiking.
hiking and what have you.
Sabar dulu, sabar. Boleh ke boleh, but kena sabar.
You have to look for it though.
Exactly.
That's the thing that sometimes some patients have the idea that, okay, I've recovered from surgery, why can't I do this now? It just the expectations, and
Again, education. They need the education and also that certainty that yes, there will come a time where you will be able to do what you love to do. But you need to, work for it. Right. Okay, Prof. Nahar, we spoke about CPAT in part 1 or cardiopulmonary exercise testing. So what kinds of improvements have you seen among your patients who go through this testing or this prep before they go for surgery?
Okay. So, first and foremost, before they come, any patients at the very beginning, will before the test itself, we will know that, oh, this patient, perhaps the result at the very beginning will be very,
Not so nice.
not good.
Okay.
Not good.
Okay.
Okay. And then even before referral, I will discuss with the surgeon, even for Prof. Azlina case. So how long? For her case, of course, I have ample of time. But for other surgeons, I will ask, okay, how much time you will give it to me? Okay, if let's say 6 weeks, okay, that's the time I need to work out and then make sure as much as to improve the CPAT results.
Okay.
So we'll do the CPAT result and then prime the patients and repeat a week before, just before the anesthetist review.
Okay.
So, and then from then itself, if there's an improvement, even though it didn't reach the so-called cutoff point, but any improvement is actually will benefits in terms of reducing the risk. Okay, there's a case where when patient first came, their fitness level quite bad. So to do a test is not possible. So we have to prime the patient first. If let's say, yes, I have 6 weeks, so maybe the test will be done maybe in week 3 or week 4. So only that one time. But during that period, we will prime the patients as if that patient going for CPAT. The type of protocol that we're going to use and how much the duration and intensity or how much effort that they need to undergo during the test. So they will have some kind of familiarization. So hopefully during the test, the patients familiar and will get good result out of that. So if let's say, for example, the results is still not so good, and then we will have discussion among the anesthetist and the surgeon. So they will bring me in and we'll talk about patients. But not just looking at the CPAT, but every time when patients come, we will have a basic assessment in terms of to look their so-called fitness. For example, patients will do each time when they come under supervision, we come for the conditioning. So we'll do 6-minute walk test, for example. So each time they come, we'll do
60-minute walk test?
6
Or
minutes.
6 minutes?
6 minutes.
60, I think takut.
Walk
6
test.
minutes. Okay,
6
okay.
minutes. So 6 minutes, how far they can walk during that 6 minutes. So the 30-meter distance, so they walk circle around that 30 meters distance, forward and back for 6 minutes. Some may only 250 meters, for example. So let's say first time 250 meters. Then the second time when they come, improve to 255 and so on until before the CPAT assessment managed to get around 300, for example, or 350. But then the CPAT test didn't show much, didn't exceed the cutoff point. But then there's improvement in terms of other assessments. So we will look the result as in general, not just the result per se. But then we need to look other component of the result also, not that just one point that where we have to the cutoff point that meant for the surgeons or the anesthetists. But we will look overall in terms of the improvement.
So it's sort of like the bigger picture.
Yeah. But then if you get that good result out of that CPAT test, then it reflects everything actually. So meaning that the level is quite sufficient for patients, the level of fitness to undergo a stressful period during operation is actually patients can proceed for the operations.
Okay. For those of you who are just joining us in part 2, we were talking about CPAT in part 1. And CPAT is a testing procedure or process where you have your patient either on a treadmill if they are an athlete, or if not, something like a bicycle. And we have all those wires stuck to your body to measure, and a mask as well, to measure and ascertain whether one is fit enough to go into surgery. Now, you also mentioned in part 1, Prof. Nahar, that CPAT isn't only used in orthopedics, but also in used by the colorectal team as well. So how does this tell us the wider value of the CPAT test or CPAT and fitness-based assessments across medical specialties?
Okay. So maybe I can add further, not just colorectal. So currently we receive a number of referrals from other surgery subspecialty.
Okay.
Colorectal, upper GI team, hepatobiliary, vascular. surgery, vascular surgery. Yeah, for those that with what do you call that? Triple
Aneurysm.
or aneurysm of the vessels. So different subspecialty request for the CPAT result for a different what do you call that approach on how to perform the procedure of operation.
Okay.
For example,
Okay.
for vascular vascular surgeon, they wanted the result. Okay, can I do open surgery or I need to do endovascular surgery, meaning that using the
Invasive.
less invasive
Okay.
compared to the open surgery. Of course, good to go for open surgery because they can get everything settled. But when they know the result is not good, then they have option. So the surgeon have option of type of surgery for the patient to reduce stress. Okay, for colorectal, of course, you need to get a good result for them because their surgery is actually very long, even can reach more than 8 hours.
Wow.
So it's a stressful situation for the patient's body. So to get a good result, in this case, we look at one parameters, what we call anaerobic threshold. It's like when you run, you hit at one point where you cannot push yourself. So it's a lactate threshold there. So when you get a good result of this, what we call anaerobic threshold, the higher the value, meaning that the patient has a reserve of oxygen in the body during the stressful time. So surgery is a stressful time. So the higher the value, meaning that the a better outcome in terms of during the operation and after operations, meaning the complication will be much less. So that's for colorectal. Even for upper GI, meaning for, these are all cancer patients, upper GI meaning for the upper gut and the lower gut lah. Upper gut, upper GI, and the lower gut for the colorectal. And then for the liver, similar. And then for patients for upper GI team, they have what we call that bariatric surgery.
Right.
Yeah, for those obese. Recently, we had 2 very morbidly obese patients, more than BMI 60.
60?
So 60.
Oh,
and then they need our assistance in terms of to get the CPAT results.
Right.
So the anesthetist very push on this to find out the results. If the result is not good, whether patients still have time or not. So if have time, they need to condition and repeat again the CPAT.
I see.
So that's how important it is nowadays.
Okay.
Of course, the end of the day is the outcome of the operation, because as much the anesthetist, they have to make sure that they can remove the tube from patient after operation. The longer the tube inside the patient, the higher the complication of infection.
Okay.
Yeah.
And like the higher chance you have to stay in ICU.
Exactly,
Yes,
ICU.
that's
And then that even the cost will be much expensive after that.
Wow, that's a lot to digest. We talk about education and
Yeah.
things that we need to know,
Yeah.
no matter how scary they can get, but we need to be able to be ready for these
Yeah.
circumstances.
Yeah.
Prof. Azlina, now how does UMSC's multidisciplinary model, we talked a little bit about that previously, you blend orthopedics, sports medicine, and also patient-centered care. How does this help ensure the best possible care for patients?
Because it treats patients holistically.
And this one in specific, we were talking about joint replacement patients. Yeah.
So when you treat a person holistically, I'm not treating you just because you're a knee or you're a hip.
Okay.
I'm treating you as a whole person. So it's not just sports medicine, the anesthetist who has to deal with you. There's dietitian, there's physiotherapist, and when everyone works together as a team, which fortunately we do have all of the different specialties under one roof, the outcome for the patient is obviously safer and, God willing, faster as well. So I think that's where we've been fortunate with multidisciplinary care. For a long time, people always used to think orthosurgeon means, or hip replacement is just a hip replacement, or a knee replacement is just a knee replacement. We realized that it's more than just the joint that needs fixing. As you've heard before, sometimes it's the patient education, their not to say spiritual, but something like internally that they have to learn to accept certain things, certain limitations sometimes after surgery. So all of that education comes, and we're lucky that we have all of each other to support each other, and we are quite consistent with our message.
Yep.
So it's not like I say one thing and he says something else.
Yes, you are all aligned.
Yes, the consistency is the key. Which sometimes when you come from different backgrounds, you don't understand that consistency. But we're like I said, fortunate that we work together for quite a long time.
Yeah.
And we understand each other's roles in patient care.
Yeah, technology also plays a role, right, Prof. Azlina, when it comes to surgery, particularly robotic assistance for total knee replacement that you mentioned just now. So how has robotics enhanced surgical precision and also the outcomes for patients? And are there any limitations?
Okay, so robotics is generally a relatively new thing in Malaysia. I think elsewhere in the world, it's been practiced for quite a while. And it is true, it is more precise because, you either tag it to a CT scan that is done. Some robots use CT scan information. Some robots use X-ray information to dictate, what's the best position or the best cuts that we need to make for joint replacement. So in that sense, it's quite precise. The literature also shows they're definitely more accurate than the naked eye, so to speak. Not to say that the conventional way is really bad, because we've been doing conventional now for many years, like 50, 60 years. So, if you're good at it, then actually you're almost on par with the robot. But I think there are some studies that are showing that in the long run, you're starting to see a divergence of the robotics doing much better than the conventional way. In the early phase, there's not much difference, but as you go long term, because the precision with joint replacement is like alignment surgery. It's like your car tire.
Yes,
Analogy always is car tire lah. So your car tire, if you don't align it well, so you get wear out, faster. So with joint replacement, you have to get the alignment right. Otherwise, the joint will wear out just as fast, even with an artificial one. So if you get the alignment correct, then God willing, it'll extend the lifespan of the implant and the surgery that you've done. So I think it's a good thing to have for long term. And patients, what we see now with patients who have robotic surgery, actually the recovery is a little bit faster because I'm not fiddling around too much in the knee. So actually the surgery becomes slightly less painful. And so as you've heard before, pain is the one that limits them in terms of their activity after surgery. So anything that helps to reduce pain is a bonus for the patient. So
we did establish before this that it is possible for patients to go back to their normal routines after surgery. But can you just let us know the reality of it?
Okay.
What's realistic when it comes to recovery and lifestyle?
Okay.
And what are the limitations that they will eventually have to face?
Okay.
Okay. Okay. Tossing each other.
I mean,
all right.
Yeah.
Okay.
Yeah.
In terms of in reality, I've mentioned about process of rehabilitation earlier, physio and so on. Okay, basically they can be functionally do like their daily chores, do activity at home, cooking, walking. The most important thing, they can walk without pain. That's what patient what do you call that?
That's
told
the main
me.
goal.
Yeah. When they came for me to condition them back, I'm pain free now. I can do almost anything lah. But they can do more things other than the house chores, or I can start back my walking. If you're talking about older adult, they can start back their walking. I can do my morning walk as usual, 30 minutes or 1 hour, or start gradual. I have one first. She started very short time, about 20-30 minutes. I said, no, it's okay. But you do it continuously and continue with the strengthening exercise that we have prescribed. They have learned from the physio, and I add some more for them to improve further.
Yeah.
So with combining those, then later on it may improve. Then in the end, they can go back walking like the usual, like
Yeah.
5 km in hour as normal as before. Walking is actually, in reality, they can do that. Of course, the higher the level of the activity, it depends on what they are
The
before.
individual. Yeah.
Yeah,
So
exactly.
I mean that's what I tell patients too. After joint replacement, the things you can do that are no 100% things in life, but
Yeah.
generally you should be able to, number one, walk. All right. Number two, stairs.
Yeah.
In general, you should be
Stairs,
able to
yeah.
do stairs. Number three, you should be able to drive.
Yep.
Although not in the first 6 weeks if your right side is being operated,
Yeah.
because now even with auto is the right side that is affected, that is used. Not because you cannot drive, but because your after surgery your leg is going to be a bit heavy, so takut you silap tekan pedal kan, you get into accidents, and that's not what we want. So those three things I say yes, for sure you should be able to go back to. Now whether you want to do prayers as normal on the floor, you will need to work for it.
Okay.
The elderly patients, most of them say, look, it's okay. I just lama semayang on the chair. I'm not gunning for it, but if I get it, it's a bonus. I say, if that's what you want, that's what you aim for, then we will try to help you. All right. So things like squatting, kneeling, prayers, as per usual, is something you will have to work a little bit more, but it's achievable if you're willing to. And as Prof Nahar said, going back to sports to the level that you were at before, a little bit may take a bit of time, but it's workable. So walks, drives, and all that within 3 months, God willing, it's okay. I find that kneeling prayers as normal may take even up to a year. Sports, depending on their physical conditioning, some are sooner, some take a little bit longer.
Slowly but surely,
You will get there.
where there is a will, there is always a way.
Yes.
Now, lastly, for the both of you, what gives you the most satisfaction or hope when you work with patients, when you hold the hands of patients who have to go through this journey? Can I start with Prof. Azlina?
Yes. I think for me it's the one that really gets me every time, that sometimes makes me cry, is when you know that they haven't walked for a long time. You know, they come in wheelchair bound, and the first day, like if surgery is today and if pain is manageable, the next day I get them to stand. And when they go, like, you know, this is how it feels like. It feels like coming home, because it's something that they've been wanting to do for a long time. You give them back their independence, their mobility. They don't rely on their family to as simple things as cleaning them in the bathroom. When they come and tell you, thank you for giving this back to me, that's
So
what makes
rewarding for you.
It's the best feeling in the world, really. Yeah.
Prof. Nahar?
Okay. When patient come back after a period of operation and an intensive physio, and then they're able to start back their activity, gone back to walking, and the first thing that they will say, just fortunately, the patients that came back to me, all are the female patients. So they came back, and then they said, I'm pain-free now. And then I can start back my walking, my walk every morning walking session. And then they appreciate, and then each time, you teach me this, you teach me that, I follow, and now I can do this, I can do that. So basically that's, even though indirectly they didn't say thank you, but in a way, the way that how they express it is already make some kind of rewarding for me. Yeah.
That's great. Thank you so much to our miracle workers, Prof. Azlina and also Prof. Nahar from UMSC, for walking us through the journey of a patient that can sometimes be overwhelming. So I think this is an important discussion and also conversation, not only for the patient themselves, but also for those who have to care for these elderly patients. Getting them ready for a major step in their lives require a lot of big decision making, a lot of patience, and also compassion. So thank you again to Prof. Azlina and Prof. Nahar. Let's create a path that is much easier and smoother for our elderly patients in particular. With that, please don't forget to QRate us by subscribing, commenting, sharing, and liking our conversation here on QRate. We'll see you in the next episode. Till then, take care, everyone. Stay safe.
Thank you.
Did you enjoy today's today's curated episode. Well, don't forget to tune in for the next episode of Curated Podcast by UMSC. To learn more about our consultants, specialties, or to book an appointment, visit umsc.my. For health tips, behind-the-scenes content, and expert insight, follow UMSC on Instagram, Facebook, TikTok, Spotify, and Apple Podcasts. Till next time!